Welcome to the discussion of Allied Neurology Module 2. So let's start with the first question. A 62-year-old male developed acute onset of Broca's aphasia and right upper and lower limb weakness, which recovered spontaneously in 6 hours. So when you have got a focal neurological deficit that has recovered within 24 hours, what do you call it? You will call it a transient ischemic attack, that is a TIA. So his blood pressure is 144 on 86 millimeter mercury at presentation. He is a diabetic and on oral hypoglycemic medications. And what is the question? The question is on calculation of the ABCD2 score. So the options are 5, 6, 7 and 8. So you know that ABCD2 score, an important topic which has been asked before as well in NEET SS. So this ABCD2 score is important for the prognostication of transient ischemic attack. Remember, it's not for the diagnosis, but for the prognostication. What is the risk of a further stroke following a transient ischemic attack? So they've asked you to calculate the ABCD2 score. So let's have a quick look at this ABCD2 score. I'm sure that most of you are familiar, especially, if you have taken your emergency duties and if you are someone who is seeing stroke in your emergencies. I think, this scoring system must be there in your fingertips. So what are the parameters to be included? ABCD2 score. A is for age more than or equal to 60 years, a score of 1. Coming to B, which is blood pressure. Remember, a systolic BP of more than 140 on 140 millimeter mercury, or diastolic BP more than 90 millimeter mercury, again score of 1. C is clinical symptoms. So if there is a unilateral weakness, you get 2 points, and speech disturbance without weakness is 1 point. And then coming to D, so there are 2 Ds, which is why it is ABCD2. The first D is duration. So if the duration of the transient ischemic attack is more than 60 minutes, you get 2 points, and 10 to 59 minutes, you will give 1 point. Okay, so maybe if a TIA would recover in less than 10 minutes, like 5 or 6 minutes, it will be 0 points. And diabetes, if the patient was on oral medications or insulin, it will still be a score of 1 point. Okay, so these are the parameters to be included. Now, if you go back to our question here, what is the age of the patient? You can see it is a 62-year-old male. So here, yes, age is more than 60. Then coming to the blood pressure, you can see that the blood pressure is 144 on 86. Remember, if the systolic BP is more than 140 or diastolic BP more than 90. So this also, you will have to take 1 point. Now coming to the clinical symptoms. See, here you can see that the patient is having both speech problems, which is an aphasia, Broca's aphasia, and also a unilateral weakness is there. So one point I just want you to understand is, suppose if there is a patient who is having both weakness and speech problem, you will not add both of them. You will take only the highest score, which is 2. So you're not going to add 2 plus 1, 3. No, it's just 2. Coming to duration, yes, it is more than 60 minutes, so it is 2. And yes, the patient is a diabetic. So 1 plus 1, that is 2, plus 4, 6 plus 1, it is 7, which is the highest score. So you know that the worst score that you can get is a ABCD2 score of 7. And if you look at the table in Harrison as well, I told you this is important for prognostication. So you see here the score ranging from 0 to 7 and a 3-month rate of stroke. If it is a score of 7, as in this patient, you can see it is almost 22%, which is very high. On the other side, if the score was say 1, the risk percentage will be 2. If it was 2, it would be 3. So like that, you should just know what is it. So anyway, the ABCD2 score in this particular patient is going to be 7. Okay, 7. And don't even think of 8 because the maximum or the worst score is actually like 7. Okay, so the ABCD2 score in this patient is 7. Okay, I hope that is very clear for you, right? And just a couple of more queries which often students ask me. Now remember, suppose if a patient is having a focal neurological deficit which completely reverses in 24 hours, but the imaging shows an infarct. Okay, so this, is it a TIA or would you categorize it as a stroke? Remember, previously we were sticking on to the time-based definition of stroke. So what is time-based definition? That is a focal neurological deficit which is completely reversing within 24 hours. So just the time was given importance. But now you are taking into account the tissue window as well. So if there is a damage to the tissue, though the patient has completely recovered, but imaging, for example, a CT scan or an MRI scan is showing evidence of an infarct, you would consider it to be a stroke. Okay, so if a relevant brain infarction is identified on brain imaging, the clinical entity is now classified as a stroke regardless of the duration of symptoms. It's an important point you should know. And another point you should know, mentioned in Harrison, is the risk of stroke after a TIA is approximately 10 to 15% in the first 3 months, and most of the events occur in the first 2 days. Okay, so when a patient presents to you with a transient ischemic attack, you know that as a part of the secondary prophylaxis, for the first 3 weeks, you will give the patient dual antiplatelet, because that first 3 weeks, okay, is very vulnerable to develop a stroke. Okay, though we say that the first 3 months, but the initial first 3 weeks is where you should be very aggressive and you have got to give dual antiplatelets followed by a single antiplatelet lifelong. Okay, so just know this value because in the super specialty entrance exams, you may get MCQs based on this. And another point I want you to understand is when you say about the definition of transient ischemic attack, please understand that the focal ischemia is not just limited to the brain. Okay, so you see this is from Bradley Neurology. So TIA is a temporary and non-marching neurological deficit of sudden onset attributable to a focal ischemia of brain, but not just brain, even if it is a retinal involvement or even a cochlear involvement. Okay, you can have a transient ischemic attack involving your anterior inferior cerebellar artery. Okay, so which can cause some sort of a transient cochlear ischemia. So that is also a transient ischemic attack. Okay, so keep that in mind. Okay, right. And yeah, so the tissue-based modification of the TIA definition has been proposed that includes any transient episode regardless of duration. So I already told you what is this tissue-based modification of the definition. And one more MCQ point you should know is, see, what is the importance of this ABCD2 score in your routine practice? See, if you're working in a high volume center where you've got a lot of cases coming into your emergency department, it may not be possible always to admit every case of a transient ischemic attack. If you are in a resource limited, like you cannot admit every patient, suppose. So in that case, you have to prognosticate the TIA. So what you say is that when the ABCD2 score is 4 or greater, then it is considered to be a moderate to high risk stroke, and that patient should be admitted to the hospital because in the immediate few days there is a chance of a recurrence of stroke. Okay, so I hope that part is very clear about transient ischemic attack, and we have covered a few points there. Now next is a question based on a trial. In the multi-center Aruba trial, so Aruba stands for a randomized trial of unruptured brain arteriovenous malformations. So in the trial, the incidence of death or symptomatic stroke was lowest in patients treated with which of the following approaches? Is it conservative medical management, embolization, microsurgery, or is it embolization followed by microsurgery? So question is about Aruba trial, and remember this trial has been mentioned in Harrison as well. Okay, Aruba trial. So let me just show you about Aruba trial. Yes, Aruba trial. I'm showing you the screenshot from Harrison. So this trial randomized patients into medical management versus intervention. So when you talk of intervention, it can either be a surgery, endovascular embolization, or a combined embolization and a microsurgery or gamma knife. Okay, so this trial was prematurely stopped for harm. So the medical arm achieved the combined endpoint of death or symptomatic stroke only in 10% of patients, whereas in those who went to the intervention arm, the harm was higher, 31%. So this trial actually argues against the routine intervention of patients presenting without hemorrhage, that is unruptured aneurysms. So Aruba trial is favoring the conservative medical management. Okay, conservative medical management in patients who are presenting with unruptured arteriovenous malformations. One important MCQ which was asked in one of the recent super specialty entrance exams. So as I told you, AV malformations can present either with rupture or maybe an unruptured AV malformation as well. Remember, 50% of the AV malformations can present with rupture, but the MCQ I'm talking about is this one. What is the pattern, most common type of rupture? So remember, although the resultant blood pattern is most often intracerebral. So it's most often intracerebral, but you can also have subarachnoid, intraventricular, all those patterns. So what is the most common type of bleed in a cerebral AV malformation? It is intracerebral or intraparenchymal. Okay, right. So you all know what is a brain AVM, which is an aggregate of arterial and venous communication with no intervening capillary network. Okay, right. Couple of more MCQ points, again important. So there are several grading systems that has been devised to categorize the AV malformations and to estimate the risk of surgery. And one of the most widely used scale is the Spetzler-Martin scale. So as per the Spetzler-Martin scale, most of the AVMs, they are graded from 1 to 5. So this is based on the sum of the scores calculated from lesion size, lesion location, whether it is involving the eloquent cortex or the non-eloquent brain, and the venous drainage pattern, whether it is superficial or deep. So if you look at this, this is from Bradley on the Spetzler-Martin grading system. You can see the lesion size categorized into small, medium and large, less than 3 cm small, 3 to 6 cm medium, and large is more than 6 cm, which is assigned 1, 2 and 3. And coming to the location, is it non-eloquent site or eloquent sites? So eloquent sites which subserve core functions of the brain, which include the sensory motor area, language area, visual area, thalamus, hypothalamus, internal capsule, brainstem, cerebral peduncle and deep cerebellar nuclei. So if that is actually involved, these are eloquent sites. So non-eloquent site is 0 and eloquent site is 1. Coming to venous drainage, superficial only, it is 0 and any deep is 1. Okay, and then what do? You have to grade it based on the total points. Grade 1 is 1 point, grade 2 is 2 points, 3 is 3 points, 4 is 4 points and 5 is 5 points. You can see that grade 1 is minimal surgical risk, grade 2 is low surgical risk, grade 3 is moderate surgical risk, grade 4 high surgical risk, and grade 5 is very high surgical risk. That's how you grade it based on the Spetzler-Martin scale. Okay, so we are clear regarding that, and we have covered most of the important MCQs as well on the AV malformations. Okay, right. So let's move to the next question. So what is the next question? The false statement regarding Tourette syndrome is option A, multiple motor and vocal tics. Then second option, onset before 18 years. Option C, tic duration more than 1 year. And option D, behavioral changes uncommon. So which is the false statement? So Tourette syndrome, as you all know, is a neurobehavioral disorder. So the term itself, says that this has got behavioral changes. It's a neurobehavioral disorder. And let me just show you the DSM-5 diagnostic criteria of the Tourette syndrome. I've taken this table exactly from Bradley Neurology. So what are the parameters included? You can see number one, there are both multiple motor and one or more vocal tics have been present at some time during the illness, although not necessarily concurrently. Second point, the tics may wax and wane in frequency, but have persisted for more than 1 year since the first tic onset. Very important. Persisted for more than 1 year since the first tic onset. The third point, onset is before the age of 18 years. Again, important. Before the age of 18 years. Fourth point, the disturbance is not attributable to the physiological effects of a substance like cocaine or another medical condition like Huntington disease or post-viral encephalitis, which can produce a secondary tic. So this is the diagnostic criteria. Okay, diagnostic criteria. So if you look at the options, you can see which they are asking about the false statement, correct? So multiple motor and vocal tics, it is correct. Onset before 18 years is a true statement. Tic duration more than 1 year is a true statement, whereas the statement behavioral changes are uncommon is a false statement. Okay, so this is the false regarding Tourette syndrome. Okay, and let me just show you this snapshot from the Harrison's textbook. So you can see in Tourette syndrome, you will have multiple motor tics, which can be accompanied by phonic tics. And age, they are saying it around 2 to 15 years with a mean age of 7 years. But we have just seen the diagnostic criteria as of now. And you can see that there are a lot of associated behavioral disorders like anxiety, depression, attention deficit hyperactivity disorder, obsessive compulsive disorder. Patients may experience personality disorders, self-destructive behaviors, difficulty in school, and impaired interpersonal relationships. These are the important points about Tourette syndrome. Okay, right. Let's go to the next question. A 64-year-old man presents with, so look at the age, it is 64. Okay, 64-year-old man presents with 1 year history of progressive memory loss. Okay, so you are thinking about a disorder where there is a cognitive impairment in an elderly. But is it just about cognitive impairment? No. Recently, the patient has developed certain abnormal movements of his arms, legs, and trunk that resulted in him retiring earlier than planned from his job as an electrician. He also has recently been diagnosed with obstructive sleep apnea. So it's not just about memory loss. You have got movement disorder as well. You have got sleep disorder as well. And his wife, who accompanies him to the visits, describes odd movements during sleep. So some abnormal movements are there during sleep, which he appears to be performing his previous work activities such as threading wires. Okay, so he's performing such activities as well. Okay, so on examination, he is also having vertical gaze palsy. What is the likely diagnosis? So multiple domains are being affected. The first two options, it's about certain autoimmune encephalitis like anti-Casper2 encephalitis, anti-Eglon 5 disease, dentatorubropallidoleucine atrophy, that is DRPLA, which is an inherited ataxia, and the neurodegeneration with brain iron accumulation. One of the commonest ones, that is the pantothenate kinase associated neurodegeneration, which was previously referred to as Haller-Walden-Spatz disease. So these are the options. See, this spectrum of manifestations in an elderly man is suggestive of a type of autoimmune encephalitis. And what type of autoimmune encephalitis? It is anti-Eglon 5 disease. Now I'll just show you the screenshot from Harrison. So you can see that the Eglon 5 disease is a chronic or subacute encephalopathy. So the presentation is subacute to chronic. So we know that there are certain autoimmune encephalitis which would present in an acute manner. For example, NMDA receptor encephalitis. It's an acute presentation, sometimes can even be subacute, but this is chronic or subacute. It is characteristically associated with certain parasomnias. You can see that in the question also, the wife was describing that he was, performing some work activities, in his sleep. Okay, so you have got some REM sleep behavior disorder there, which is the activity which I just described. So this may be associated with other bulbar symptoms, gait abnormalities. Movement disorders, we just saw that you can have chorea, you can have distal myoclonus, you can have tremor, dystonia, spasms, very important, oculomotor dysfunction, and in less than half of the cases, you can have cognitive decline. So you can see this is presenting in the elderly, that is the early 60s. So you've got abnormal sleep initiation with undifferentiated NREM sleep, which is associated with frequent vocalizations and quasi-purposeful movements. And another important point about Iglon-5 disease is the association with HLA-DRB1 and HLA-DQB1, which is also important. Okay, so these are some important points about anti-Iglon-5 disease, which I think is an expected question. Okay, anti-Iglon-5 disease. I would also take you to this table from Bradley. Remember, even in Harrison also, you've got good descriptions about the various autoimmune encephalitis, but I thought that I'll share this table from Bradley with you, wherein the features are wonderfully given. So autoimmune encephalitis with antibodies to the cell surface antigens. So what about autoimmune encephalitis? So let us see the important types of autoimmune encephalitis. I'm just highlighting on the most important points. First, what are the key points about NMDA receptor encephalitis? Patient is having psychiatric symptoms, seizures, psychiatric symptoms, seizures, memory deficits, dyskinesias, and autonomic dysfunction. It is mostly seen in young adults, mostly females, and there is an association with which tumor? Ovarian teratoma. And with immunotherapy, there is a good response. 80% of cases have full or substantial recovery. And then the GABA B receptor encephalitis, which presents as a limbic encephalitis with prominent seizures with a median age of 62 years, with associated malignancies like small cell lung cancer or other neuroendocrine tumors. You can have a full or partial recovery. You also have got a GABA A receptor encephalitis, which presents with a rapidly progressive severe encephalopathy with refractory seizures. And this one will show extensive flare, T2 cortical, subcortical abnormalities, and they would often have frequent coexisting autoimmunities. So you will have anti-TPO antibody positivity, anti-GAD antibody positivity, and half of the patients will have good response to immunotherapy. Okay, that's about GABA A and GABA B. AMPA receptor encephalitis can also present as a limbic encephalitis. Remember, you may be asked questions, which of the following encephalitis presents with limbic encephalitis? So here, the affection is of middle-aged women. 70% would have an associated malignancy like a breast, thymus or lung, and 70% would improve with therapy. Then coming to the LGI1 encephalitis, which is again presenting as a limbic encephalitis. And remember, this is again in the elderly. The median age is 60 years. And 60% cases would have hyponatremia, which can result in delirium as well. Less often you can have REM sleep behavior disorders. 30 to 40% cases can have facio-brachial dystonic seizures. This is very, very important. Facio-brachial dystonic seizures like this, this is an important feature of the LGI1 encephalitis. Facio-brachial dystonic seizures like this. Okay. So that is a feature. 80% would have recovery with immunotherapy. Caspar-2 encephalitis can present with Morvan syndrome, limbic encephalitis, neuropathic pain, and also features of peripheral nerve hyperexcitability. And they also might have coexisting autoimmunities, and 70% will have full or substantial recovery. Another important, again, potential question is the DPPX encephalitis, wherein the patient can present with agitations, hallucinations, tremor, paranoia, myoclonus seizures. Less often cerebellar signs, hypereclipsia, and symptoms are usually preceded by severe diarrhea. This is very important. So GI symptoms, severe diarrhea is an important feature of DPPX encephalitis. Okay, right. And here also you get a partial but meaningful, improvement. And the Iglon-5 encephalitis I have just discussed with you. Encephalopathy with REM and NREM parasomnias. Obstructive sleep apnea. Remember in the question there was obstructive sleep apnea. Stridor preceded or concurrent with gait dysfunction, chorea and cognitive decline. It's usually chronic, very important. This is very, very important. It's slowly progressive. It's less often rapid progressive like other autoimmune encephalitis. And the problem is it is largely unresponsive to immunotherapy. Okay. So if you go back to the question, yeah, so it is anti-Iglon-5 encephalitis. That is the answer for this question. But I want you to have a good idea about the other types of autoimmune encephalitis as well.